Hello and welcome to today's assignment. Today we are looking at Nsaids and prostaglandin analogs. So Nsaid is an initial for non-steroidal anti-inflammatory drugs. And these are drugs that are simply used to treat three conditions: inflammation, pain, and fever. Pain, inflammation, and fever is normally exacerbated by production of pro-inflammatory chemicals such as prostaglandins. So NSAIDs, they work by simply blocking the production of these prostaglandins and thus relieving inflammation, pain, and fever. So to understand how NSAID works, we have to review the process of inflammation. So inflammation is simply the body's response to harmful stimuli following tissue injury or an infection. So during inflammation, the immune cells normally release an enzyme that is referred to as the phospholipidase A2. So this enzyme, its role is to convert phospholipids, the ones that are found in the cell membrane, into a 20-carbon polyunsaturated fatty acid referred to as arachidonic acid. So this arachidonic acid is a substrate for two major enzymes. We have cyclogenase, the one that is abbreviated as COX, and 5-lipoxygenase. Now, for the purpose of our discussion, we shall dwell on the COX so as to understand our subject better. So this cyclogenase, abbreviated as COX, is an enzyme that exists in major two isoforms. So the first isoform is the COX-1. COX-1 is a constitutive enzyme. This enzyme is actively expressed throughout our bodies and is responsible for production of two pigments. We have thromboxane and prostaglandins. So the duo, they help stimulate normal body functions such as secretion of the protective gastric mucus, regulation of gastric acid, promotion of platelet aggregation, especially the thromboxane is involved here, and lastly, maintenance of blood flow. On the other hand, cyclogenase 2, or abbreviated as COX-2, is not expressed constantly, so it must be turned on to function. It is generally referred to as inducible enzyme. So it's normally produced at inflammatory sites during this inflammation process. So this COX-2 produces two pigments where we have prostaglandin A2 and prostacyclin. So these two, prostaglandins and prostacyclin, they normally cause vasodilation and they also attract immune cells into that inflammatory area. Furthermore, they also act on neurons that normally detect pain, the one that we refer to as the nociceptors. And how do they affect the nociceptors? They make sure that the nociceptors are more sensitive to stimuli by now lowering the threshold for activation. Thus, someone is able to feel more or perceive more pain. Okay? So the prostaglandin E2 and the prostacyclin are also involved in stimulation of the hypothalamus, and in this process they increase the body temperature, generally leading to fever, right? Fever in a patient. So prostaglandin E2 also causes uterine contractions. Furthermore, they can also lead to decrease in secretion of gastric acid, also increasing production of protective mucus in the stomach. So in conditions such as inflammation, we find pain or fever. Where we have pain or fever, you can just simply use NSAIDs to inhibit cyclogenase, and in the process, you will decrease the production of prostaglandins. Now, based on how selectivity these NSAIDs are, Okay, based on the selectivity for these COX enzymes, these NSAID drugs are divided into 3 major groups. Remember, also selectivity for the COX enzymes will help us explain the efficacy, safety, and even side effects associated with these drugs. So the 3 groups of the NSAIDs, we have number 1, we have the selective COX-1 inhibitor, then we'll go to non-selective, and then lastly the COX-2 inhibitors. So starting with the first COX-1 inhibitors, we have examples like the ketorolac. The ketorolac, this is a drug that is used to treat acute pain, especially after surgery. Number 2, we have the flubiprofen, and then we have ketoprofen. We have endomethacin. Endomethacin is normally used to close patent ductus arteriosus in neonates and premature infants. And then lastly, we have low dose aspirin. Remember, when you have high dose, the high dose drug is going to be non-selective. So we can look at aspirin, which is commonly referred as the acetylsalicylic acid as its chemical name. This drug irreversibly inhibits both COX-1 and COX-2. It's normally taken per orally, and when that is done, its absorption is mostly in the ileum of the small intestines. So once absorbed into the bloodstream, this aspirin irreversibly inhibits COX-1 in the platelets by covalent acetylation, thereby decreasing the production of thromboxane A2 in platelets. So since thromboxane A2 in platelets is a platelet activator, this makes aspirin to be very useful as an antiplatelet medication. So aspirin irreversibly prevents the platelets from synthesizing new COX enzymes, and aspirin will effect will persist over time until there is enough new platelets that can be produced in order to release more COX-1 enzyme. So this normally leads to increased bleeding time without necessarily affecting the thrombin and the PT and the PTT time. Aspirin is metabolized in the liver into a component referred to as salicylate. Remember, this salicylate has no antiplatelet effect but has anti-inflammatory properties. So this salicylate works by inhibiting COX-2, thereby reducing prostaglandin production. Right? Remember, COX-2 is more related with prostaglandin production. So this will lead to decreased inflammation, pain, and fever. So it's commonly used to treat headaches and musculoskeletal pain based on these facts. It can also be used as short-term treatment for chronic pain like in osteoarthritis, rheumatoid arthritis, and ankylosing spondylitis. Remember, effects of aspirin are dose dependent, so you find that at low dosage, especially below 300 milligrams per day, aspirin will be working as an antiplatelet medication. But when you give medium dosages of between 300 to 2400 milligrams per day, aspirin will be used in that case as antipyretic and analgesic. Lastly, if you give higher dosages of over 2400 milligrams per day, then in that case aspirin will act as anti-inflammatory medication. So we also have low dosages like the baby aspirin, the junior aspirin in the form of 81 milligrams tablets, and this one can be used as a long term to prevent heart attacks, strokes, blood clot formation in patients at higher risk of developing blood clots, just like the pre-eclamptic mothers. So aspirin generally needs special attention, so you are advised not to give aspirin to reduce fever in children with viral infection, as this can lead to rise in Reye's syndrome. Remember, Reye's syndrome is a condition that is characterized by liver damage and excessive encephalopathy. However, you must know that aspirin can be used to reduce fever in Kawasaki's disease. Also, you need to know that aspirin overdose can be fatal. So early symptoms of salicylic poisoning, you need to know them, and they include tinnitus, deafness, headache, and vomiting. At higher dosages, you find salicylate can directly stimulate respiratory centers and cause hyperventilation and respiratory alkalosis. So as the dosage increases, salicylate can start to inhibit oxidative phosphorylation, which can be used to generate energy in the aerobic pathway. Remember, the body will switch to anaerobic respiration, which now is going to produce more lactic acid. So increased lactic acids will cause an elevated iron gap, resulting in a condition that we refer to as metabolic acidosis. So as the pH decreases because of the acidosis, salicylate now will shift towards an ionized form, which is salic acid. And this salic acid can easily cross the blood-brain barrier, causing seizures and even coma in patients. So we have a note whereby we have to know that we have other NSAIDs like ibuprofen, naproxen, indomethacin, which can generally be used to reduce inflammation during acute gout attack. But in the case of low dose of aspirin, it has to be avoided in a patient with gout because it normally competes with uric acid for excretion in the kidney. Thus, it will exacerbate the disease, the gout disease. But at higher doses, it will promote excretion of the uric acid from the body, and thus will relieve the patient. All right, so we have to take note of that. Currently, we don't have an antidote for aspirin overdose, so no specific antidote for now. But instead, we can do some treatment based on the symptoms. And in the first place, we have treatment could include administration of activated charcoal. Now, this activated charcoal normally binds to aspirin and prevents its absorption in the GI tract. Furthermore, we can carry out alkalization of urine by sodium bicarbonate. So this will help facilitate salicylate excretion. So this patient can also be put on a vent for support for the breathing, and we can also manage the metabolic acidosis in an attempt to help the patient. All right. Generally, we have a few side effects related to COX-1 inhibitors. Remember, in the GI, we have COX-1 mediated production of prostaglandin E2 and prostaglandin I2. So, they do play a role in the synthesis of protective mucus as well as regulating gastric blood flow. So if you inhibit this process by use of the COX-1, it's going to increase the risk of the GI bleeding and also development of peptic ulcers, right? And remember, COX-1 are more associated with this problem. Number two, we also have COX-1 mediated production of thromboxane A2, and thromboxane A2 normally promotes platelet aggregation. So if you block this pathway, the blockade is going to result in antiplatelet effects. Thus, there is going to be increased risk for bleeding. So this is particularly evident with the use of aspirin, which irreversibly inhibits COX-1. Platelets, furthermore, they do lack a nucleus, so they can't make a new enzyme. So aspirin-induced antiplatelet can persist for several days even after aspirin therapy has been stopped. Thirdly, prostaglandins A2 and 1,2 can cause dilation of the renal afferent arteriole, which is very key in maintaining glomerular filtration rate. Now, this may not be so significant, but their effect will be felt more in patients who are having conditions like heart failure or kidney failure, which has significantly impaired renal flow. So you find in that case, prostaglandins will help to dilate so that more blood can be delivered to the kidney. So in the case where you have blocked this one using the COX-1 inhibitors, it can lead to false reduced perfusion, and this normally activates the RAS system, renin-angiotensin-aldosterone system, which could result into development of hypertension. Lastly, COX-1 agents also have a protective effect on the cardiovascular effect, and this is due to the platelet properties agents. So remember we said we are going to block this thromboxane A2, so that means the platelets will not be able to aggregate together. So that means that now we are going to reduce the chances of having clots, stroke, myocardial infarction, which could be beneficial for the patient. Now, the first group of NSAIDs, we say there was the COX-1 selective, okay? The second category is the non-selective inhibitor. So these ones, they block both COX-1 and COX-2. Examples, we have naproxen, we have ibuprofen, we have piroxicam, and we have diflunisal, right? Okay, so next we have now the selective COX-2 inhibitors. Examples, we have the meloxicam, we have the diclofenac, we have the selecosib, and the etodalac, right? Okay, so we have general side effects of COX-2 inhibitors, and to understand this, you need to picture a blood vessel supplying a heart, for example. So under normal condition, we normally have a balance effect between prostacyclin and thromboxane A2. So if you try to reflect from our introductory page, you find that prostacyclin is normally produced by COX-2 in the endothelium of the blood vessel. So this prostacyclin is responsible for vasodilation and inhibition of platelet activation. Thromboxane A2, on the other hand, is primarily produced by COX-1 in the platelets. So this thromboxane A2 will be responsible for causing vasoconstriction and promotion of platelet aggregation. So when you have selective inhibition of the COX-2, what is affected, guys? It will tip the balance in the favor of thromboxane A2, which is primarily produced by COX-1, all right? So this will lead to vasoconstriction and increased chances of having platelet aggregation. So thus we can say that the main side effect of the COX-2 inhibitors is that there is increased risk of cardiovascular events. So there is likelihood of having myocardial infarction, stroke, because there is increased chances of platelet aggregation. Okay, apart from the NSAIDs, we also have the prostaglandin analogs. Okay, generally we know prostaglandins have various beneficial effects in our body. So when you have the analogs, these are just what scientists have come up with so that they can be able to mimic the endogenous prostaglandins, so that you have more effects of this based on how important the prostaglandins are. So generally, prostaglandins will be inserting their effects by interacting with the G protein coupled prostaglandin receptors. So we have at least two major categories. We have the prostaglandins E1 analogs, such as we have alprostadil, lubiprostone, and misoprostol. We also have another group of prostaglandins analog, like the F2A analogs, such as the bimatoprostol, latanoprostol, and travoplast. So, starting with the first example, which is alprostadil. It has two major therapeutic uses. First of all, it is normally used in treatment of erectile dysfunction. You find when it's applied onto the urethra, it can act via direct stimulation of the cyclic AMP pathway, and this decreases intracellular calcium levels, and this allows relaxation of the trabecular mesh muscle and dilatation of the cavernosa arterioles. This consequently leads to improved erectile function. Allopurinol, on the other hand, is also used in neonates, and this is in neonates with congenital heart defects. And this is used to temporarily maintain the patency of the ductus arteriosus. Now, for the status, you find that a ductus detritus is a blood vessel found in babies before birth that normally allows blood to bypass the pathway to the lungs. So this blood vessel typically closes shortly after birth, but keeping it open in certain babies with heart defects may improve blood flow and oxygenation. So infusion of this drug, allopurinol, will relax the ductus arteriosus and supports its patency until surgery can now be performed on that baby. The second prostaglandin analog, we have the lubiprostone. It's used in the treatment of chronic constipation. It works by activating the type 2 chloride channels in the epithelial cells lining the intestines. So by stimulating these channels, you find lubiprostone will promote secretion of chloride, followed by passive secretion of water, sodium, which can increase the liquidity of the intestinal contents. And this secretion also stimulates intestinal smooth muscles contractions, which facilitate the passage of the stool. This is the second prostaglandin E1 member. The third member is misoprostol, which is used to treat and prevent stomach ulcers, particularly in patients who are taking these Nsaids. So misoprostol can also be used to induce labor, and that's why it's used in treatment for therapeutic abortion. Right? So the mode of mechanism is that it works by binding to prostaglandin receptor on the gastric parietal cell and causes decrease in intracellular cyclic AMP, leading to decreased activity of proton pump and thus inhibiting acid secretion. Misoprostol can also be used to protect the stomach by lining by increasing the bicarbonate, which normally neutralizes the excessive acid, and also mucus production that will protect the layers from the effects of the hydrochloric acid. So by interacting with the prostaglandin receptors in the uterus, misoprostol can also cause softening of the cervix, uterine contraction, leading to expulsion of uterine contents. The second group of prostaglandin analog is prostaglandin F2A analogs, and in this case we have examples like the bimatoprost, we have also latanoprost and travoplasts. So these drugs, they are used to treat open angle glaucoma, and they work by increasing the outflow of aqueous fluid from the eye, thus lowering the intraocular pressure. In normal cases, the intraocular pressure should supposed to run between 20 to 21 millimeters of mercury. So the latanoprost and the travoprost, they lower the intraocular pressure by interacting with the prostaglandin F receptors that are located throughout the eye. Bimatoprost is also known for its unique side effects. So you find that when you use the bimatoprost, it will lead to elongation and darkening of the eyelashes, which also makes it very useful in treatment of eyelash hypotrichosis. So for starters, eyelash hypotrichosis is a condition in which an individual has inadequate amount of eyelashes. So as a protective barrier to the eye, you understand where this condition can become a problem. So when When this happens, you find that the leading cause of this condition is mostly associated with genetics. So when treating patients using the bimatopros, we can also benefit from the side effect, which helps treat the eyelash hypotrichosis. You can notice the difference between before the treatment and after the treatment. You can see it has enhanced the eyelashes in that case, right? Also here. Okay, guys, so lastly, we have the prostacyclin analogs, and this is the last group of the analogs. And examples, we have iloprost and the treprostil. Okay, both these drugs are used to treat pulmonary artery hypertension, and they simply work by increasing production of cyclic AMP, which in turn leads to decreased levels of intracellular calcium in the pulmonary vascular smooth muscles. So this will lead to vasodilation, resulting in significant reduction in pulmonary vascular resistance and enhanced cardiac index. So the major route of administration, we have it's normally inhaled, the iloprost, right? So inhalation is by the nebulizer, right? Okay, we are still yet to find its compatibility with the mechanical ventilation. Still studies are still ongoing about the same. Okay, guys, that wraps the end of this presentation on the Nsaids, right? A link will be popping up. You could also attempt the free quiz just to cement you and your knowledge and your understanding on the same topic.